Hello friends, welcome to my YouTube channel. Starting with surgery question bank. First question. Air embolism in neurosurgery is maximum in sitting position. If the depth of invasion of melanoma is 1 to 2 mm, the surgical margin required is 1 to 2 cm. In video assisted thoracoscopic surgery, for better vision, the space in the operative field is created by collapse of ipsilateral lung. Stab knife 11 is commonly used for incision and drainage. IV cannula gauges 14G orange, 16G grey, 18G green, 20G pink, 22G blue, 24G yellow, 26G violet. Size of Foley's catheter: black 8 FR, grey color 10 FR, white color 12 FR, green color 14 FR, orange color 16 FR, red color 18 FR, yellow color 20 FR, purple 22 FR, blue 24 FR. Nesloff syndrome is a recurrent occurrence of pneumonia. Kressel lines are tension lines in skin. To measure nasogastric tube length, measure from the tip of the nose to ear, then to siphisternum. The preferred position for nasogastric tube insertion is sitting position. Maury's sign is seen in carcinoma. A patient developed a nodular lesion with central telangiectasia over the nose. Diagnosis of this patient is basal cell carcinoma. Patient has relief in pain in knee chest position. Diagnosis of this patient is acute pancreatitis. Mattock's maneuver is also known as left medial visceral rotation. It is done to explore and handle zone 1 and 2 retroperitoneal injuries, which include aorta, left iliac, and also pelvic vessels. Trochea's sign of latent tetany is a medical sign observed in patients with low calcium. This sign may be positive before other manifestations of hypocalcemia such as hyperreflexia and tetany. Trochea's sign is enlarged left supraclavicular lymph node seen in intra-abdominal malignancies. Trochea syndrome is migratory thrombophlebitis seen in patients with intra-abdominal malignancies, most commonly associated with pancreatic carcinoma. Romovac suction drain is most commonly used after modified radical mastectomy. Lithotrite is used in cystolitholapaxy, that is, perurethral removal of small stones from urinary bladder. Penrose drain is a soft, flexible rubber tube used as a surgical drain to prevent the buildup of fluid in a surgical site. Pemberton maneuver is a physical examination tool used to demonstrate the presence of latent pressure in the thoracic inlet, most commonly seen in retrosternal goiter but can be seen in superior vena cava syndrome as well. The maneuver is achieved by having the patient elevate both arms until they touch the sides of the face. A positive Pemberton sign is marked by the presence of facial congestion and cyanosis, as well as respiratory distress after approximately 1 minute. T-tube cholangiogram is a special X-ray procedure done with contrast media, that is X-ray dye, to visualize the bile duct after the removal of gallbladder. The bile ducts drain bile from the liver into the duodenum, that is first part of the small bowel. This procedure will visualize any stones remaining in the bile ducts. Most common complication while inserting central venous catheter is pneumothorax. Most common catheter related complication is catheter related sepsis. If bleeding continues to come even after performing Pringle maneuver, the source of bleeding is from hepatic vein or from inferior vena cava. Carroll's triangle is used in vascular anastomosis. Ideal time to remove scalp suture is 7 days. Disparity of the bowel ends during end-to-end anastomosis is corrected by Cheadle maneuver. The preservative used while packing catgut suture is isopropyl alcohol. Aberdeen's knot is taken in continuous sutures. Regarding vascular surgery distal to popliteal artery, suture is done with polypropylene. Here 6-0 suture is used. Needle is passed from within outwards. In abdominal surgery, lumbar suture is referred to seromuscular suture. Infection rate is less in monofilament suture as compared to multifilament. Knot security is less in monofilament suture as compared to multifilament. Memory is better in monofilament suture as compared to multifilament sutures. Naturally occurring absorbable sutures are absorbed by enzymatic degradation. Polypropylene is a non-absorbable suture. When knots are cut short, the free ends of ears should be left at least 1 to 2 mm long. Catgut gets absorbed in 45 to 60 days. Vicryl gets absorbed in 60 to 90 days. PDS gets absorbed in 180 days. Vicryl, the commonly used suture material, is a copolymer of glycolide and lactide. Polydioxanone is an absorbable monofilament synthetic suture. The integrity of polypropylene suture in holding tissues together can last indefinitely. Braided suture material may be a nidus for infection. Polymeric synthetic suture materials cause of minimal inflammatory reaction. Absolute contraindication of heart transplantation includes HIV infection, irreversible pulmonary hypertension, malignancy. Amputated digits are preserved in plastic bag in ice. Allopurinol is used in organ preservation as free radical scavenger. A kidney transplant between identical twins is an example of isograft. Acute cellular rejection following solid organ transplantation occurs between 5 to 30 days of transplantation. Hyperacute rejection is due to preformed antibodies. Most important HLA for organ transplantation and tissue typing is HLA-D. Renal transplantation is most commonly done in chronic glomerulonephritis. Commonest malignancy in renal transplant recipient is skin cancer. Principal cause of death in renal transplant patient is infection. Investigation of choice in the early phase of renal transplant is ultrasonogram. An elderly male presents 2 months after renal transplantation with nephropathy. The viral etiological agent here can be polyoma virus BK. A patient had undergone a renal transplantation 2 months back and now presented with difficulty breathing. X-ray showed bilateral diffuse interstitial pneumonia. The probable etiological agent would be cytomegalovirus. Expanded criteria for liver donation includes age of donor may be more than 65 years, hepatitis B serology positive, can be taken from individual with mild hepatic steatosis. Reduced liver transplants is a part of liver segment transplanted into recipient depending upon requirement. The advantage of bladder drainage over enteric drainage after pancreatic transplantation is better monitoring of amylase levels. Site of transplantation in islet cell transplant for diabetes mellitus is injected into the portal vein. Dr. Christian Bernard is associated with heart transplant. Most common cause of death in intestinal transplant is sepsis. Order of anastomosis in lung transplant is pulmonary vein, bronchus, pulmonary artery. Type 3C Southampton grading is large volume hemoserous discharge. Pyrexia due to wound infection occurs commonly after 5th post-op day. Most common organism responsible for UTI in the hospital is E. coli. Most common nosocomial infection is urinary tract infection. Serosanguinous discharge is the most pathognomic sign of impending burst abdomen. Q-SOFA score includes respiratory rate, systolic BP, altered mental status. Foaming liver is seen in gas gangrene. Features of SIRS, that is systemic inflammatory response syndrome, includes temperature more than 100 degree Fahrenheit, less than 96.8 degree Fahrenheit, respiratory rate more than 20, heart rate more than 90, leukocytosis, PCO2 less than 32 mmHg. Systemic inflammatory response syndrome, that is SIRS, is an inflammatory state affecting the whole body. It is the body's response to an infectious or non-infectious insult. Cellulitis is a bacterial infection involving the inner layers of the skin. It specifically affects the dermis and subcutaneous fat. The area of infection is usually painful. Bacteria most commonly involved in cellulitis are Streptococci and Staphylococcus aureus. Erysipelas is an acute infection typically with a skin rash, usually on any of the legs and toes, face, arms, and fingers. It is an infection of the upper dermis and superficial lymphatics, usually caused by beta hemolytic group A Streptococcus bacteria on scratches or otherwise infected areas. Erysipelas is more superficial than cellulitis and is typically more raised and demarcated. Southampton grading is Grade 0 normal healing, Grade 1 normal healing with mild bruising, Grade 2 erythema plus other signs of inflammation, Grade 3 clear or hemoserous discharge, Grade 4 pus or purulent discharge, Grade 5 deep or severe wound infection with or without tissue breakdown. Classic W's of postoperative fever include wind, water, wound, walking, wonder drug. Wind meaning atelectasis, which can be seen in postoperative day 1 to 2. Next is water meaning urinary tract infection, which can be seen in postoperative day 2 to 3. Wound meaning wound infection, that is seen in postoperative day 3 to 7. Next is walking. Walking means deep vein thrombosis or thrombophlebitis. This is caused during postoperative day 5 to 7. Next W is wonder drug. This can cause drug fever mainly in the postoperative period more than 7. Most common organism responsible for UTI in hospital is E. coli, followed by Proteus mirabilis, Staphylococcus epidermidis, and Streptococcus faecalis. Pleomorphic adenoma is most common neoplasm of salivary gland. True about parotid tumor include facial nerve involvement indicates malignancy, superficial parotidectomy is the treatment of choice, pleomorphic adenoma is most common variety. Exclusively found in parotid gland is Warthin's tumor. Hot spot on technetium-99 is seen in adenolymphoma. Tumor with perineural invasion is adenoid cystic carcinoma. Swelling of deep lobe of parotid gland presents as swelling in parapharyngeal space. Ramavati, a 40-year-old female, presented with a progressively increasing lump in the parotid region. On an oral examination, the tonsil was pushed medially. Biopsy showed it to be pleomorphic adenoma. The appropriate treatment is conservative total parotidectomy. After removal of parotid gland, patient is having sweating on the cheeks while eating. In this complication seen after parotidectomy, the auriculotemporal nerve, which contains parasympathetic secretomotor fibers to parotid gland, is fused with greater auricular nerve. The starch iodine test is useful to diagnose Freier syndrome. Newman and Seabrook's operation is used for repair of parotid fistula. The parotid duct is known as Tenson's duct. Nerve which lie in association to Warthin's duct is lingual nerve. Most common location of ectopic submandibular salivary gland tissue is angle of mandible. In submandibular gland surgery, the nerve least likely to be injured is inferior alveolar nerve. Landmark for facial nerve during parotid surgery is digastric muscle, tragal pointer, retrograde dissection of distal branch. Ackermann's tumor is squamous cell carcinoma. Ranula is extravasation cyst of sublingual glands. Excision of ranula is associated with injury to submandibular duct. Regarding stones in the submandibular gland, 80% of the stones occur in the submandibular gland. Stones are the most common cause of obstruction within the submandibular gland. Patient presents with acute swelling in the region of the submandibular gland. Malignant salivary gland tumors are painful, present with skin ulceration. Here cervical lymphadenopathy is present. Microscopically positive margin is an indication of radiotherapy in pleomorphic adenoma of parotid. Swiss cheese pattern is seen in adenoid cystic carcinoma. Best diagnostic modality for parotid swelling is FNAC. Most common tumor of salivary gland in children is hemangioma. Salivary gland tumor associated with Epstein-Barr virus infection is lymphoepithelioma. The commonest site of branchial cyst is upper one-third of the sternocleidomastoid muscle. True about carotid body tumor. Carotid body tumor commonly seen in high altitude habitants. 10% have family history. Carotid body tumor may metastatize. Carotid body tumor is associated with non-chromaffin paraganglioma. Carotid body tumor is unilateral. Here, surgical resection is the treatment. Cystic hygroma may be associated with Turner syndrome. Preoperative MRI is crucial in cystic hygroma. Cystic compressible translucent swelling in the posterior triangle of neck is cystic hygroma. Cystic hygroma is known to occur in neck, axilla as well as mediastinum. True about branchial cyst. Branchial cyst is lined by squamous epithelium. Cyst wall consists of lymphoid tissue. Fluid contains cholesterol crystals. Peak age of presentation of branchial cyst is third decade. Commonest treatment of branchial cyst is excision. The most common site of internal opening of a branchial fistula is at the tonsilla fossa. Excision of the hyoid bone is done in thyroglossal cyst. Infection of thyroglossal cyst as well as inadequate removal of thyroglossal cyst. These both are causes of thyroglossal fistula. Addison's test is positive in cervical rib. Structures removed in radical neck dissection includes 11th nerve, tail of parotid, parotid nerve, post-auricular nerve. In post-radical neck dissection shoulder syndrome, restricted range of shoulder movement, pain in the shoulder as well as shoulder drooping can be seen. Level 5 cervical nodes include posterior triangle nodes. Structures removed in functional neck dissection is neck nodes and submandibular salivary gland. In extended supraomohyoid neck dissection, lymph node dissection is done up to 4. Secondaries in the neck with no obvious primary malignancy is most often due to carcinoma nasopharynx. A patient comes to you with a firm, non-mobile pulsatile mass in neck. Imaging shows typical Lyrae sign. The Lyrae sign refers to the splaying of the internal and external carotid by a carotid body tumor. Classically described on angiography is also visible on CT angiography. It is typically seen in carotid body tumor, also known as potato tumor. Most common site of laryngeal carcinoma is glottis. True about nasopharyngeal carcinoma include nasopharyngeal carcinoma is associated with Epstein-Barr virus infection. Nasopharyngeal carcinoma is common in Chinese population. Dry salted fish is a risk factor for nasopharyngeal carcinoma. Most common site of origin of nasopharyngeal carcinoma is fossa of Rosenmuller. Trotter's triad includes conductive deafness, palatal paralysis, and also ipsilateral temporoparietal neuralgia. Most common presenting feature of nasopharyngeal carcinoma is cervical lymph node enlargement. Treatment of choice for nasopharyngeal carcinoma is radiotherapy. Carotid artery blowout is associated with radical neck dissection. Pectoralis major myocutaneous flap is based on thoracoacromial artery. Delphian lymph node is level 6 of neck lymph node. Lymph node stations of neck include level 1A submental, level 1B submandibular, level 2 upper jugular, level 3 middle jugular, level 4 lower jugular that is virchow node, level 5 posterior triangle, level 6 central group of lymph node that is Delphian node, level 7 mediastinal lymph node. In detail about modified radical neck dissection. In all types of modified radical neck dissection, we remove lymph nodes 1 to 5 and submandibular salivary gland. Depending on which structures we preserve during neck dissection, modified radical neck dissection is of 3 types. Type 1, we preserve spinal accessory nerve. Type 2, we preserve spinal accessory nerve and internal jugular vein. Type 3, we preserve spinal accessory nerve, internal jugular vein and sternocleidomastoid muscle. Type 3 neck dissection is also referred to as functional neck dissection. In short, to remember, classical radical neck dissection, lymph nodes dissected is level 1 to 5. Other structures excised are sternocleidomastoid muscle, internal jugular vein, spinal accessory nerve, and also submandibular gland. A patient has carcinoma tongue in the right lateral aspect with lymph node of 4 cm size in level 3 on the left side of neck. Stage of carcinoma of tongue here is N2. Pre-malignant lesion of carcinoma oral cavity include erythroplakia, leukoplakia, candidiasis. Most common site of oral cancer is tongue. Stain used to diagnose pre-malignant condition of lip is toluidine blue. Treatment of choice for carcinoma of lip of less than 1 cm is excision. A patient with cheek cancer has a tumor of 2.5 cm located close to and involving the lower alveolus. A single mobile ipsilateral lymph node measuring 6 cm is palpable. The TNM stage is T4N2M0. Carcinoma of tongue most commonly occur at lateral border of anterior two-third. Ludwig's angina is an infection of the cellular tissues around submandibular salivary gland. Dentigerous cyst arises from an unerupted permanent tooth. Rushton bodies are hyaline bodies of odontogenic cyst. Most common site of carcinoma oral cavity is tongue. Most common site of carcinoma oral cavity in India is buccal mucosa. For T1 and T2 lesion of carcinoma lip, surgery is the treatment of choice. If 1/3 or less than 1/3 of lip is involved, V or W shaped full thickness excision with lateral margin of 5 mm plus primary closure is done. If more than 1/3 of lip is involved, flap reconstruction, that is Abbe flap reconstruction or Etlander's flap reconstruction is done. For T3 and T4 lesion, combined radiation and surgery is done. Most common site of tongue carcinoma is lateral border of tongue anterior two-third. Most common site of oral carcinoma is tongue. Most common site of oral carcinoma in India is buccal mucosa. Dentigerous cyst arises from unerupted tooth. Most common in lower third molars. Cyst also contains unerupted teeth. X-ray shows unilocular cyst or soap bubble appearance. Next is about dental cyst. Dental cyst develops at the apices of caries tooth with necrotic pulp, more common in upper jaw. X-ray shows circular radiolucent area in relation to root of normally erupted tooth. Margins may be sclerotic. Calculation of percentage of burns is based on Wallace rule of 9. Wallace rule of 9 for adults include face 9%, anterior trunk 18%, back 18%, both upper extremities 9% each, both lower extremities 18% each, genitalia 1%. Next is Wallace rule of 9 for children. Face 18%, anterior trunk 18%, back 18%, both upper extremities 9% each, both lower extremities 14% each, genitalia 1%. For assessing the percentage of burns in children, we have Lund and Browder charts and Burko formula. Out of these, the preferred method to assess the burns in children is Lund and Browder charts. In first degree burns, only epidermis is affected. Healing is by 3 to 6 days without scarring. The appearance here is erythema, blanches with pressure. In second degree superficial burns, epidermis and superficial dermis is affected. Skin appendages are intact. Healing is by 1 to 3 weeks. Scarring is unusual. In second degree deep burns, epidermis and most of the dermis are affected. Most of the skin appendages are also destroyed. Healing is more than 3 weeks, often with scarring and contractures. In third degree burns, epidermis and all of the dermis are affected. Destruction of all skin appendages can be seen. Here, healing does not happen. Severe scarring and contractures can be seen. Parkland resuscitation formula include crystalloid of 4 ml per kg per TBSA burn. Brooke resuscitation formula includes crystalloid of 1.5 ml per kg per TBSA burn and also colloid of 0.5 ml per kg per TBSA burn and also 2 liter free water. Galveston resuscitation formula which is used in pediatric patients. Here we use crystalloid of 5000 ml per meter square burnt area plus 1500 milliliter per meter square of total area. Zones of thermal injury was given by Jackson. Innermost zone includes zone of coagulation. Here irreversible injury has already occurred. Middle zone consists of zone of stasis. Here damage has occurred but can be reversed by proper treatment. Outermost zone includes zone of hyperemia. It appears red because of increased blood flow but the damage has not occurred. First degree burns is localized injury to epidermis. Superficial second degree burns, here epidermis plus dermis up to papillary dermis is involved. Deep second degree burns include epidermis plus dermis up to reticular dermis is involved. Third degree burns, here complete epidermis plus dermis is involved. Marjolin's ulcer is a low-grade squamous cell carcinoma arising from the edge of a non-healing ulcer, most commonly from the post-burn contracture. Characteristic feature of Marjolin's ulcer include lymphatic spread, which is uncommon as it does not have lymphatic supply. It is radio-resistant as blood supply does not reach the scar tissue. It is painless as the underlying nerves are destroyed. Escharotomy is the treatment of third degree burns in which there is circumferential eschar formation. Dressing is used in a patient of deep second degree burns. Most common cause of death in burns patient overall is sepsis, so antibiotics are also important for the burns patient. Most common cause of theatre fire is electrosurgical equipments followed by lasers. Most common cause of death in burns patient overall and in late period is sepsis. Most common cause of death in burns patient at the site of burns is asphyxia. Fluid of choice in resuscitation in burns patient is ringer lactate. Fluid of choice for resuscitation in pediatric burns is dextrose normal saline. An adult whose both lower limbs are charred along with genitalia has 37% of burns. Percentage of burn in children is best assessed by Lund and Browder chart. In a patient with burn wound extending into the superficial epidermis without involving the dermis would present with painful area of wound, blanchable erythema and also healing of the wound spontaneously without scar formation. Blisters are seen in superficial second degree type of burns. The ideal temperature of water to cool the burn surface is 15 degrees Celsius. Safest strategy of treatment for a patient of inhalational burn injury who has presented within 4 to 5 hours is elective endotracheal intubation. The most important aspect of management of burn injury in the first 24 hours is fluid resuscitation. Silver sulfadiazine is effective against Pseudomonas and is used in burns patient. Most common cause of theatre fire is electrosurgical equipments. Most common cause of death due to burns in early period is hypovolemic shock. In burns management, ringer lactate is the fluid of choice. True statements regarding fluid resuscitation in burns patients. Oral fluid must contain salts. Most preferred fluid is ringer lactate. Half of the calculated volume of fluid should be given in first 8 hours. Myoglobinuria is seen in electric burn. Electrocution, 15% deep burns in adults and 10% scalds in children. These all cases require hospitalization. Metabolic derangements in severe burns are increase in corticosteroid secretion, hyperglycemia, neutrophil dysfunction. Exposure treatment is done for burns of the head and neck. Domestic low voltage electric supply can cause contact wound, cardiac arrest as well as cardiac fibrillation. A third degree circumferential burn in the arm and forearm region, peripheral pulse and circulation is very important for monitoring. Head and face burn in infant is 18%. The cold water treatment of burns has the disadvantage that it increases the chance of infection. Thiersch graft is Partial thickness type of graft. Skin graft stored at 4 degrees Celsius can survive up to 2 weeks. Full thickness skin graft can be taken from back to neck. Within 48 hours of transplantation, skin graft survives due to plasma imbibition. Humpy's knife is used to take partial thickness graft. Dermatome is used to take partial thickness graft. Partial thickness skin graft has better uptake as compared to full thickness graft. Cosmetic appearance of full thickness graft is better than the partial thickness graft. After partial thickness graft have been taken, donor site can be reused. Abbe Etlander flap is used for lip. Primary source of blood supply to latissimus dorsi muscle is thoracodorsal artery. Best heel flap is reverse sural artery flap. A 3 to 6 cm scalp defect is closed by local flap. Sebaceous cysts do not occur on sole. Dercum disease is commonest in the back. Hidradenitis suppurativa is found to occur in axilla. Pott's puffy tumor is subperiosteal abscess of frontal bone. Margins of squamous cell carcinoma is everted. Keratoacanthoma is self-healing nodular lesion with central ulceration. Sebaceous cyst is a non-fluctuant compressible mass and has a central dark comedone opening that is punctum. Cysts are usually asymptomatic. It is commonly found on face, neck, chest, upper back, scrotum, and genitals. If cyst ruptures, it may closely resemble a furuncle with tenderness to palpation, erythema, and swelling. A foul-smelling yellowish cheese-like material discharged from the skin may be described. Dercum disease is a rare condition characterized by multiple painful lipomas. These lipomas mainly occur on the back, trunk, upper arms, and upper legs. Most commonly occur between 35 to 50 years, more common in women. Clinical features: multiple lipomas and neuropathic pain are the cardinal symptoms of Dercum disease. Treatment: it is usually targeted towards pain relief rather than lipoma removal. Most common bacterial infection in lymphedema is Streptococcus. Most common type of primary lymphedema is lymphedema praecox. In India, most common cause of unilateral lymphedema of lower limb is filariasis. Grade 1 lymphedema means edema disappearing after overnight rest. Chronically lymphedematous limb is predisposed to thickening of the skin, recurrent soft tissue infections, and also sarcoma. Necrotizing lymphadenitis is characteristically seen in Kikuchi disease. Homan's operation, Charles operation, and also Sistrung's operation, these all are operation of congenital lymphedema. Primary lymphedema is associated with Milroy's disease. Prevalence is 2%. Lymphangiosarcoma may occur. The most common site of lymphangiosarcoma is post-mastectomy edema of arm. In HIV infection, diffuse lymphadenopathy in a person who is clinically well is usually a sign of persistent generalized lymphadenopathy. Brenner's grading of lymphedema includes grade 0, histological abnormalities are seen, not clinically evident. Grade 1, pitting edema is seen, subsides with elevation. Grade 2, non-pitting edema is seen, not relieved with elevation. Grade 3, irreversible skin changes are seen, fibrosis and papillae are also seen. In a patient with symptomatic varicose veins, where the great saphenous vein has reflex and a diameter of 9 mm, the preferred surgical treatment is radiofrequency ablation or laser ablation. Thromboembolism after pelvic surgery is usually from femoral vein. Protein C deficiency, protein S deficiency, factor V lead-in mutation, these all are congenital cause of DVT. DVT occurs most commonly after total hip replacement. Investigation of choice in DVT is Doppler. For prophylaxis of DVT, warfarin is not used. For the prophylaxis of DVT, heparin, pneumatic shocks, garment, graded stocking, these all are used. Earliest sign of DVT is calf tenderness. White leg is due to deep femoral vein thrombosis. The duration of heparin therapy in deep vein thrombosis is 7 to 10 days. 55-year-old male with recent history of intracranial hemorrhage with DVT is an indication for inferior vena cava filter in a patient with DVT. Pneumatic compression device is used for deep vein thrombosis. Patient had a retrograde pelvic thrombophlebitis and it is progressed to bilateral iliofemoral occlusion, and now the presentation is blue leg. Clinical assessment of deep vein thrombosis is highly reliable. Most common clinical presentation of deep vein thrombosis is pain and tenderness. Some cases may directly present as pulmonary thromboembolism. Varicose vein of size less than 3 mm can be best treated by sclerotherapy. Drug used for sclerotherapy of varicose vein are ethanolamine oleate, polidocanol, sodium tetradecyl sulfate. Brody Trendelenburg test is positive in saphenofemoral incompetence. In varicose ulcer, always examine deep venous system. Here biopsy should be taken from chronic ulcer. Varicose ulcer is associated with Klippel-Trenaunay syndrome. Cocket and Dodd operation is used for subfacial ligation. Perforator present around knee joint is Boyd's perforator. Bisgard treatment is for venous ulcer. Subfacial endoscopic perforator surgery, that is SCPS, it is used in the treatment of incompetent perforators. Lipodermatosclerosis is most commonly seen on medial aspect of leg. Contraindication for surgery of varicose vein is deep vein thrombosis. Klippel-Trenaunay syndrome is associated with port vein stain, varicose vein, limb lengthening. Pulsatile varicose vein in young adult is due to AV fistula. Most common cause of superficial thrombophlebitis is intravenous catheter. Elderly male has 0.5 mm dilated tortuous vein in the posterior part of right calf. The stage as per CEAP classification is C1. May-Turner or Cocket syndrome involves left iliac vein compression. Harvey sign is related to the use of venous filling after emptying a length of vein. The most common complication of varicose vein stripping is ecchymosis. Treatment for venous ulcer. Bisgard method is used to reduce edema, increase venous drainage so as to promote ulcer healing. It consists of elevation, massage of the inturated area and whole calf, passive and active exercise, care of the ulcer by regular cleaning with povidone iodine plus hydrogen peroxide and also dressing with Uzole. Antibiotics depending on culture sensitivity. Skin graft after ulcer granulates. Lipodermatosclerosis refers to changes in the skin of the lower legs. It is a form of panniculitis, that is, inflammation of the layer of fat under the skin. Signs and symptoms include pain, hardening of skin, change in skin color, that is, redness, swelling, and a tapering of the legs above the ankles. It is associated with varicose veins, so that it is most commonly present on medial aspect of the legs. CEAP classification. C for clinical classification, E for etiological classification, A for anatomic classification, P for pathophysiologic classification. C for clinical classification, which includes C0, that is no visible or palpable signs of venous disease. C1 telangiectasia or reticular veins. C2 varicose veins. C3 edema. C4A pigmentation or eczema. C4B lipodermatosclerosis or atrophy. C5 healed venous ulcer. C6 open venous ulcer. Etiological classification includes EC, that is congenital, EP primary, ES secondary or post-thrombotic, EN, that is no venous etiology identified. Next is anatomic classification, which includes AS superficial veins, AP perforator veins, AD deep veins, AN, that is no venous location identified. Pathophysiological classification includes PR, that is reflex, PO, that is obstruction, PRO, that is reflex and obstruction, PN, that is no venous pathophysiology identified. Maximum tourniquet time for the upper limb is 2 hours. True regarding Buerger's disease. Men are usually involved, occurs below 50 years of age, smoking is predisposing factor. Intermittent claudication is most common in calf muscle. It is relieved by rest. Atherosclerosis is important predisposing factor. Lumbar sympathectomy is of value in the management of distal ischemia affecting the skin of the toes. Removal of L1 ganglion in sympathectomy results in infertility. An adult patient with leg pain and gangrene of toe, his angle to brachial arterial pressure ratio would be less than 0.4. Features of acute ischemia of limb are perishing cold, paralysis, and pain. Neurological features are most common in thoracic outlet syndrome. Resection of first rib relieves symptoms of thoracic outlet syndrome. Positive Adson's test can be seen in thoracic outlet syndrome. A 38-year-old male who is chronic smoker and has a history of uncontrolled hypertension came to casualty with sudden onset of extremely severe tearing chest pain radiating to back. There is unequal pulse in both the upper extremities and X-ray chest showed widened mediastinum. The most probable diagnosis in this patient is dissecting aortic aneurysm. Fogarty arterial embolectomy catheter is used in the removal of embolus from the blood vessel. Intermittent claudication is defined as pain in muscle on exercise only. True about Leriche syndrome is it is caused by aortoiliac occlusion. Erection or impotence problem can be seen. Gluteal claudication is also seen in Leriche syndrome. A 40-year-old male patient who is chronic smoker presented with a long history of intermittent claudication and blackish discoloration of toes. Preferred treatment is amputation. A 40-year-old male patient who is a chronic smoker came to hospital with history of pain on walking. You advised an angiography whose image has been shown as corkscrew collaterals. Probable diagnosis is Buerger's disease. Raynaud's syndrome occurs in SLE, rheumatoid arthritis, and also cryoglobulinemia. True about Raynaud's phenomenon is Raynaud's phenomenon shows spasm of vessels. It is seen more in females. Exposure to cold exacerbates the symptoms. Reimplantation time for lower limb is up to 6 hours. Commonest type of AV fistula is congenital. AV fistula can safely be ligated if Allen's test is positive. Most common site of peripheral aneurysm is popliteal artery. Most common cause of pseudoaneurysm is trauma. Most common part of a subclavian artery to be affected by stenosis is first part. In subclavian steal syndrome, reversal of blood flow in the ipsilateral vertebral artery can be seen. Best graft for femoropopliteal bypass is autologous vein. Collagen, gel foam, and thrombin are temporary embolization agent. The size at which elective surgery is indicated in abdominal aortic aneurysm is 5.5 cm. Classification system which is used for intra-abdominal aortic aneurysm is modified Crawford classification. The best management for radiation-induced occlusive disease of carotid artery is carotid endarterectomy. Adson's test is the test used for thoracic outlet syndrome, which is also known as Scalene test. Complication of surgery for thoracic outlet syndrome is pneumothorax, brachial plexus injury, and also long thoracic nerve injury. True regarding peripheral vascular disease is falsely elevated ABPI may be found in diabetes. Ramesh met with an accident with a car and has been in deep coma for the last 15 days. The most suitable route for the administration of protein and calorie is by jejunostomy tube feeding. Best vein for TPN is subclavian vein. Most dangerous complication of TPN is pneumothorax. Contraindication of enteral nutrition is intestinal obstruction, severe pancreatitis, severe diarrhea, IBD. Indication of enteral nutrition is intestinal fistula. Ratio of carbohydrate is to fat is to protein in TPN solution is 60 is to 20 is to 20. Following TPN, one expects weight gain after 7 days. Most common organism responsible for catheter-related sepsis in TPN is Staphylococcus epidermidis. A patient on total parenteral nutrition for 20 days presents with weakness, vertigo and convulsions. Most probably he has hypomagnesemia. Serial transverse enteroplasty, that is STEP. This procedure is done for short bowel syndrome. Best vein for inserting central line in trauma is internal jugular vein. Most common catheter-related complication of TPN is catheter-related sepsis. Most common complication of TPN is hyperglycemia. Serial transverse enteroplasty, that is STEP. It is a surgical procedure used primarily in the treatment of short bowel syndrome. Another procedure for short bowel syndrome is Bianchi procedure. Percutaneous endoscopic gastrostomy is an endoscopic medical procedure in which a tube, that is PEG tube, is passed into a patient's stomach through the abdominal wall, most commonly to provide a means of feeding when oral intake is not adequate. This provides enteral nutrition despite bypassing the mouth. Enteral nutrition is generally preferable to parenteral nutrition. Major techniques for placing PEGs, that is percutaneous endoscopic gastrostomy, have been described, that is Goderer-Ponsky technique, Russell introducer technique and also Seldinger technique. Refeeding syndrome is a syndrome consisting of metabolic disturbances that occur as a result of reinstitution of nutrition to patients who are starved, severely malnourished or metabolically stressed due to severe illness. When too much food or liquid nutrition supplement is consumed during the initial 4 to 7 days of refeeding, this triggers synthesis of glycogen, fat and protein in cells to the detriment of serum concentration of potassium, magnesium and phosphorus. Cardiac, pulmonary and neurological symptoms can be signs of refeeding syndrome. The low serum minerals, if severe enough, can be fatal. First step in trauma is maintenance of airways. In surgical stress, hormones like ADH, cortisol and ACTH is increased. Early stage of trauma is characterized by catabolism. In case of clearing airway, neck tilt, chin lift and also mouth gag is involved. Long saphenous vein should be avoided for intravenous infusion in the management of abdominal trauma. A female with suspected child abuse was brought to casualty with severe bleeding from perineum. The first line of management is airway maintenance. Most common organ involved in blunt injury to abdomen is spleen. Investigation of choice for blunt trauma abdomen in unstable patient is USG. Investigation of choice for diagnosing intra-abdominal bleeding in a stable patient is CT scan. A driver wearing seat belt applied brake suddenly to avoid accident. Most common organ injured in seat belt injury is mesentery. Preferred incision for abdominal exploration in blunt injury abdomen is always midline incision. Best diagnostic test in stable patient with blunt trauma abdomen is CECT scan. FAST stands for Focused Assessment with Sonography for Trauma. A patient is brought to the emergency as a case of head injury following a head-on collision road traffic accident. His BP is 90 by 60 mmHg. Tachycardia is present. Most likely diagnosis is intra-abdominal bleed. A patient with abdominal injury presents to emergency department with signs of peritonitis and shock. Airway and breathing were secured and IV fluids were started with 2 large bore cannulas. The next line of management should be exploratory laparotomy under general anesthesia. Damage control surgery is minimal intervention done to stabilize the patient and do the definitive surgery later. Aims of abbreviated laparotomy is hemostasis. In abdominal compartment syndrome, there is decreased cardiac output, decreased urine output and also decreased venous return. Abdominal compartment syndrome is characterized by hypercarbia and respiratory acidosis, hypoxia due to increased peak inspiratory pressure, hypotension due to decrease in venous return. Organ most commonly damaged in penetrating injury of abdomen is liver. The probable cause of sudden death in a case of superficial injury to neck is air embolism through external jugular vein. A man comes to emergency with stab injury to left flank. He has stable vitals. The next step in management is CECT. In a blast injury, liver is the least vulnerable organ to the blast wave. A 30-year-old gentleman, after sustaining road traffic accident, presented in an emergency department with BP 100 by 60 mmHg, pulse 120 beats per minute, and CT scan showed splenic laceration at inferior border after 2 units of blood transfusion. Patient's conditions are BP 120 by 70 mmHg and pulse 84 per minute. The next line of management is continue the conservative treatment and take subsequent measures on monitoring the patient. A child presents in casualty in stable condition after a blunt abdominal trauma associated with splenic trauma. Treatment of choice is observation. True about blunt abdominal trauma with splenic rupture is spleen is the most common organ to be involved. Gastric injury is mostly related to penetrating trauma. Treatment of gastric injury is simple debridement and suturing. Gastric injury heals well and fast. A young patient presents with a massive injury to proximal duodenum, head of pancreas, and distal common bile duct. The procedure of choice in this patient should be pancreaticoduodenectomy or Whipple's operation. A 40-year-old man brought to the emergency room with a stab injury to the chest. On examination, patient is found to be hemodynamically stable. The neck veins are engorged and the heart sounds are muffled. The statements true for this patient is cardiac tamponade is likely to be present. Echocardiogram should be done to confirm pericardial blood. The entry wound should be sealed with an occlusive dressing. Sitaram, a 40-year-old man, met with an accident and comes to emergency department with engorged neck veins, pallor, rapid pulse and chest pain. Diagnosis is cardiac tamponade. A patient is brought to casualty with severe hypotension following a road traffic accident. No external injury is evident. The cause of hypotension is intrathoracic and abdominal bleed. Treatment of acutely developing massive left-sided hemothorax in a young male after an accident is tube thoracostomy. Treatment of flail chest with respiratory distress is IPPV. Best approach in thoracic trauma is anterolateral thoracotomy. Treatment of choice in severe flail chest is IPPV. The immediate treatment of choice in most cases of flail chest is analgesics. Steering wheel injury on chest of a young man reveals multiple fractures of ribs and paradoxical movement with severe respiratory distress. X-ray showed pulmonary contusion on right side without pneumothorax. The initial treatment of choice is endotracheal intubation and mechanical ventilation. True about flail chest are flail chest ultimately leads to respiratory failure. Flail chest can cause paradoxical respiration. It involves fracture of 2 or more ribs. Simple rib fracture should be treated with analgesics, physiotherapy as well as early ambulation. Traumatic diaphragmatic injury is most commonly due to trauma. Abdominal approach is the most favored method. Left side rupture occurs due to weak left hemidiaphragm at point of entry of embryonic origin. Diagnosis of traumatic rupture of diaphragm is by laparoscopy. Seatbelt causes injury to duodenum. Prognosis in head injury is best given by Glasgow Coma Scale. A 20-year-old male came to casualty with head injury. Examination reveals normal consciousness and blood in the tympanic membrane. Most likely cause is basilar fracture. After head injury, biconvex lenticular shaped hematoma in CT scan is characterized of extradural hemorrhage. The commonest source of extradural hemorrhage is middle meningeal artery. A patient with sudden headache, vomiting and unconsciousness, diagnosis is subarachnoid hemorrhage. A patient presents in emergency with a cervical spine fracture. First thing to do is immobilize the cervical spine. A patient who has received tetanus toxoid 12 years back Now presented with a clean wound over forearm with slight loss of tissue. The appropriate management to be given to this patient is give only one dose of TT. Limb salvage can be done in nerve injury, bone injury, and also muscle injury. Management of missile injuries include excision of all dead muscles, removal of foreign bodies, and leaving the wound open. When bullet is shot above pubic symphysis in midline directed backwards, first organ to get injured is abdominal aorta. In resection of muscle with history of trauma or crush injury, resection depends on contractility of muscle, color of muscle, and also bleeding punctuate spots. During reconstruction of an amputated limb, fixation of the bone should be done first. Hypotension in acute spinal injury is due to loss of sympathetic tone. Due to decelerations, aorta can be ruptured at places where it is fixed at ligamentum arteriosum, behind the crura of diaphragm, and also at aortic valve. During resuscitation, artifacts of fractured ribs most commonly involve third to fifth ribs. Management of trauma includes A, B, C, D, E. A for airway and cervical spine position, B for breathing, C for circulation with hemorrhage control, D for disability, E for exposure. Revised trauma score consists of respiratory rate, systolic blood pressure, Glasgow Coma Scale. Pulse rate is not included in revised trauma score. Trauma and Injury Severity Score, that is TRISS, TRIS. TRIS combines age, mechanism of injury, that is blunt or penetrating, revised trauma score, and also injury severity score. Mangled Extremity Severity Score, that is MESS, consists of following parameters, that is shock, patient's age, limb ischemia, and also energy that caused the injury. In triage, we prioritize patients by using color coding, that is green for ambulatory patients, yellow for medium priority patients, red for those who need immediate intervention or transfer, black for moribund or dead patients. Most common organ injured in blunt trauma of abdomen is spleen. Most common organ injured in penetrating trauma of abdomen is liver. Investigation of choice for blunt abdominal trauma in hemodynamically unstable patient is FAST. Initial investigation for blunt abdominal trauma in hemodynamically unstable patient is FAST. Investigation of choice for blunt abdominal trauma in hemodynamically stable patient is CECT. Initial investigation for blunt abdominal trauma in hemodynamically stable patient is FAST. CT scan is investigation of choice for a patient of blunt abdominal trauma who is hemodynamically stable. Whenever you encounter a patient of blunt abdominal trauma, first thing you need to assess is the hemodynamic stability of the patient. CECT is the investigation of choice in stable patients. FAST is investigation of choice for unstable blunt trauma. FAST is nothing but a ultrasound examination done in the casualty to look for intraperitoneal fluid accumulation, and based on the results of FAST, further management is determined. So ultrasound is the initial investigation to be done for blunt abdominal trauma in a stable patient. Physiological consequences of increased intra-abdominal pressure includes decreased cardiac output, decreased central venous return, decreased visceral blood flow, decreased renal blood flow, decreased glomerular filtration, increased cardiac rate, increased pulmonary capillary wedge pressure, increased peak inspiratory pressure, increased central venous pressure, increased intrapleural pressure, increased systemic vascular resistance. Most common organ injured in penetrating abdominal injury is liver. Most common organ injured in blunt abdominal injury is spleen. Most common organ injured in gunshot injury is small intestine. Duodenum is retroperitoneal structure and is injured rarely, and most of the time the injury is because of penetrating injury rather than blunt abdominal trauma. Keher sign is seen in splenic rupture with subdiaphragmatic blood collection. The blood collected in subdiaphragmatic space irritates the diaphragm and causes a referred pain to the left shoulder. Conservative management is the treatment of choice for splenic trauma. Splenectomy is a last resort for the treatment of splenic injury. Cullen sign is seen in acute pancreatitis and denotes periumbilical discoloration. High spinal cord injuries can result in systemic hypotension because of loss of sympathetic tone. Hypotension associated with high spinal injury can be treated by alpha agonist phenylephrine. Most common blood transfusion reaction is febrile non-hemolytic transfusion reaction. Massive blood transfusion is defined as whole blood volume in 24 hours. Direct Coombs test should be done immediately to best confirm an unmatched blood transfusion reaction. For 35 days, blood can be stored with CPDA. CPDA is an anticoagulant used for storage of whole blood in blood bank. C for citrate, P for phosphate, D for dextrose and A for adenine. Cryoprecipitate is stored at minus 40 degrees Celsius. Blood grouping and cross-matching is must prior to infusion of dextran. Coagulopathy developing during surgical exploration is best treated with transfusion of RBCs is to fresh frozen plasma is to platelets in the ratio of 1:1:1. Rosenthal syndrome is seen in deficiency of Levin factor. TRALI is more likely if blood donor has been multiparous woman. TRALI is defined as acute onset of hypoxia and bilateral pulmonary infiltrate that is temporarily related to a blood transfusion. It must occur within 6 hours following transfusion. TRALI is more likely when blood donor is previous transplantation, previous transfusion or a multiparous woman. Received risk factor include duration of cardiopulmonary bypass, older age or repeated platelets or fresh frozen plasma. Massive blood transfusion leads to hyperkalemia. Hypothermia, hypomagnesemia and hypocalcemia are the side effects of massive blood transfusion. Most important complication of massive blood transfusion is coagulopathy. Direct Coombs test or direct antiglobulin test on post-transfusion blood sample from patient should be done to detect antibodies directed against the transfused RBCs. Cryoprecipitate is stored at minus 40 degrees Celsius for the period of 2 years. Human albumin is stored at room temperature for the period of 2 years. Platelets are stored at room temperature in an agitator for a period of 5 days. Packed red cells are stored at 2 to 6 degrees Celsius for a period of 5 weeks with SAG-M as an anticoagulant. Dextran is a polysaccharide polymer of varying molecular weight producing an osmotic pressure similar to plasma. Dextran interferes with platelet function, hence it is recommended that total volume of dextran should not exceed 1000 ml. Some important points about direct Coombs test. Direct Coombs test is a type of clinical blood test used to detect the antibodies or complement proteins attached to the RBCs. It detects antibodies or complement proteins attached to the RBCs. Uses washed red blood cells without plasma. Direct Coombs test detects autoimmune hemolytic anemia. Indirect Coombs test is another type of Coombs test used to detect antibodies produced against foreign red blood cells. Indirect Coombs test detects the developed antibodies against foreign RBCs. Uses serum. Indirect Coombs test is used prior to the blood transfusion and in prenatal testing of pregnant women. An immunocompromised patient presents with fever, dyspnea and altered sensorium in the emergency department. His heart rate is 125 beats per minute, BP is 90/66 mm mercury and his central venous pressure is low. Patient is suffering from septic shock. A 19-year-old girl sustained blunt abdominal trauma. She was diagnosed of having splenic rupture. Her pulse is 110 per minute and BP is normal. She is tachypneic with respiratory rate of 22 per minute and she is anxious. Her approximate blood loss is 750 to 1500 ml. Blood clot of the size of a clenched fist is roughly equal to 500 ml. Shock index formula is heart rate by systolic BP. Modified shock formula is heart rate by mean arterial pressure. A patient with spine, chest, and abdominal injury in road traffic accident developed hypotension and bradycardia. Most likely reason is neurogenic shock. Best parameter to assess the efficacy of fluid resuscitation in a shock patient is urine output. A patient with hemorrhagic shock will have tachycardia due to sympathetic overactivity. In hemorrhagic shock patients, we get cold extremities due to peripheral vasoconstriction. Hemorrhagic shock occurs due to excessive blood loss from the body. In hemorrhagic shock, we get peripheral vasoconstriction, so we have increased peripheral vascular resistance. Patient is in shock and IV cannulation is not possible. Intraosseous line for IVF is done within 1.5 minutes. Best parameter to assess the volume of resuscitation to be given is CVP. In both cardiogenic and obstructive shock, there is dysfunction at the level of heart, which leads to an increase in central venous pressure due to accumulation of venous blood. Wound dehiscence is typically seen around postoperative day 5 to day 7 after open laparotomy. Salmon colored fluid coming out of the wound is the first sign of wound dehiscence. If evisceration occurs after wound dehiscence, emergency abdominal closure is required. Reoperation is needed to avoid peritonitis. The tensile strength of the wound never reaches the tensile strength of the normal skin. Maximum tensile strength recovery after a wound is 80% of that of normal skin, that is achieved after 3 months of the time since wound had occurred. Ratio of collagen type 1 to type 3 at the end of remodeling phase is 4:1. Staging of bed sore includes Stage 1 non-blanching erythema, no breach in epidermis. Stage 2 partial thickness of loss of skin, which includes epidermis and dermis. Stage 3 full thickness skin loss, not through underlying fascia. Stage 4 exposed muscles, bones, and subcutaneous tissue. Most common site of pressure sore is ischium. Frequency of pressure sore is ischium more than, greater trochanter more than, sacrum more than, heel more than, lateral malleolus more than, medial malleolus. Criteria for clean wound: non-traumatic elective procedure where surgical site is not inflamed or contaminated, no break-in aseptic technique. Criteria for clean contaminated wound is elective opening of respiratory, gastrointestinal, biliary or genitourinary tract with minimal spillage, minor break-in aseptic technique. Criteria for contaminated wound is gross contamination which is present at the surgical site without active infection, including spillage of the GI tract, incision into acute non-purulent inflammation. Major break-in aseptic technique can be seen here. Criteria for dirty wound is active infection at the surgical site, surgery of a traumatic wound with retained foreign body or fecal contamination, ruptured viscus present. Active infection meaning purulent exudate is encountered here. Examples of clean wound: inguinal hernia, joint replacement, thyroidectomy, mastectomy, abdominal aortic repair. Next is examples of clean contaminated wound: cholecystectomy, CBD exploration, elective GI surgery including colonic resection and gastrectomy. Example of contaminated wound: spillage during elective GI surgery, perforated gastric ulcer, perforated appendix, open fracture and human bite. Example of dirty wound is perforated diverticulitis, frank pus, fecal peritonitis. Local factors affecting wound healing are infection, ischemia, foreign body, hematoma, movement, mechanical stress, and necrotic tissue. Systemic factors affecting wound healing are diabetes, ionizing radiation, temperature, advanced age, vitamin C deficiency, vitamin A deficiency, steroids, doxorubicin, jaundice, uremia, malignancy. Criteria for viability of muscle include color, contractility, consistency, and capillary bleeding. Color means dead muscle has dark, unhealthy color which has lost its sheen. Contractility means dead muscles do not twitch when held by forceps. Consistency means dead muscle has lost its turgor and its mushy in consistency. Capillary bleeding means dead muscle does not bleed at cut ends. Deglowing injury is an injury involving avulsion of the skin and subcutaneous tissue from the underlying structures, usually a result of trauma. As the blood supply to the skin is hampered, the main concern is to retain the viability of the skin. The worst position of the scar is sternum, as it has the maximum risk of formation of keloid in this position. The risk is maximum in the triangle formed between two shoulders and the sternum. The golden period for wound is 6 hours. It includes the time with which a fresh wound can be closed primarily. Golden period for trauma is 1 hour. Golden period for esophageal perforation is 24 hours. Esophageal perforation can be closed primarily in 24 hours since the time of perforation. Proper sterile technique, pre-operative antibiotics, and use of monofilament sutures. These all are methods to reduce the surgical site infection. Shaving of the operative site before operation increases surgical site infection. Chronic osteomyelitis is a contraindication for vacuum-associated dressing. Negative pressure wound therapy, that is NPWT, is a therapeutic technique using a vacuum dressing to promote healing in acute or chronic wounds and enhance healing of second and third degree burns. Contraindications for negative pressure wound therapy includes malignancy in the wound, untreated osteomyelitis, non-enteric unexplored fistula, necrotic tissue with eschar. Principles of negative pressure wound therapy includes stabilization of wound environment, reduced edema, microdeformation, macrodeformation. Keloid is more common in the age group of 10 to 30 years of age. Keloid is not limited to the distribution of the scar. Keloid tends to grow beyond the boundaries of the scar. Keloid does not occur just after the operation. It occurs between 3 months to 3 years after the wound has occurred. Hypertrophic scar does not have a familial predisposition. It is more common on the flexor aspect of the body. It is more common in children. Hypertrophic scar usually occurs equally in males and females. Drug used for intralesional injection of keloid is triamcinolone. During the surgical procedure, tendons should be repaired before nerves. A patient with grossly contaminated wound presents 12 hours after an accident. His wound should be managed by thorough cleaning with debridement of all dead and devitalized tissue without primary closure. The main aim of performing a delayed primary repair is prevent wound infection. Keloids contain an excess of type B collagen. Type 3 collagen is weaker than type 1 collagen. Skin wound edges should not be closed too tightly. Vascular anastomosis is always done with non-absorbable sutures. Longitudinal arteriotomies are closed with vein patch, but the transverse ones, like for femoral embolectomy, can be closed primarily. Glues have a place in approximation of tissues. Sequence of repair after injury is bone, then extensor tendons, flexor tendons, arterial anastomosis, nerves, veins, skin closure. First line treatment for keloid is intralesional triamcinolone injection. Other treatment options for keloid are by applying pressure with local molds or elasticated garments. Next is silicone gel sheeting, excision and steroid injection, excision and postoperative radiation like external beam or brachytherapy.